Good evening. A warm welcome to all of you. Today we are having our third episode of Troubleshooting in Pediatric Cardiology, and this time we are focusing on percutaneous management of simple and complex coarctations. We have very eminent speakers with us, and as usual, our series will be divided into two sessions. Like the first session will be short talks on the topic, and the second will be a panel discussion of challenging cases. So once again, on behalf of all the organizers, I extend a warm welcome to the speakers, the presenters, the panelists, the moderators, and the delegates. I now invite Dr. Krishnamurthy, Professor and Head of Division of Pediatric Cardiology, to moderate the next session and to welcome the speakers.
Am I audible?
Yes, sir.
Yeah, thank you. So welcome all. We are now going to start the session 1, and there is no better person than Dr. Peter Zartner to give this talk on percutaneous options for the management of coarctation in the newborn. I recently published a paper in a 600 grams baby, low birth weight baby, very sick child who had renal failure. Without contrast, they did. So let us hear from him. Please welcome.
Good evening, everybody. Thanks for inviting me, Dr. Krishnamurthy. Hello to everybody joining this session. I'm very curious about the discussion later on. Okay. My topic is percutaneous options for management of newborn with severe coarctation. This is the fetal development of the heart from the day 15 to day 50, and you can see how complex the configuration of the aortic arch is over time. This is a morphing video done by electron microscopy, and you see the beauty of the rotation between day 25 to 35. It's really complex construction. Though there are different kinds of coarctation. This is a normal arch. This is a circumscript single coarctation. This is a hypoplastic distal arch, and here we have a complete hypoplastic arch. This is a complete hypoplastic aorta, like in a Williams-Beuren syndrome. There's another classification in relation to the duct, the preductal and postductal and the juxtaductal coarctation. This is the other classification. So the primary goal of treatment in the coarctation in newborn is to improve and secure organ perfusion. This can achieve by getting rid of the coarctation, optimize the abdominal blood flow, improve antegrade perfusion of the organs, reduce ductal diastolic runoff, and reduce the ventricular afterload. There are primarily two strategies: primary correction or primary prevention and secondary correction. This can be achieved by surgery, intervention, and in parts by medication too. So the interventional treatment of coarctation in neonates, the first option is a balloon dilation. You can achieve a good immediate relief and result. It's easy to perform. You have a broad variety of low-profile balloon catheters. But in the end, it's not a really lasting option. The gradient will reoccur after hours or some days. So the better option is the stent implantation. You have a good lasting result. It's a more critical procedure. Reinterventions may become necessary, and the vessel access, at least in very small children, may become critical. This is what I'm going to talk about: the problem of using stents in newborns. Every stent has, or most of the stents have, an upper maximum diameter, which limits the growth of the vessel. Though I'm going to talk about 4 groups: the bare metal stent, just one slide, growth stent, biodegradable stents, and a coronary stent in the use for treating coarctation. There is a bare metal stent from the Cook Medical Company, Formula stent, which can be used in newborns. If they are not too small, you need at least a 5 French sheath for implantation. You can redilate them up to 12 and some up to 16, 17 millimeters, and you can even break them. There is a paper from the Birmingham group with all the details and very much information of how to do it. Now to the group of growth stents. We had the baby stent from the Osipka company. This is a stent running through 4-French delivery sheath, can be implanted with 6 millimeters and can be redilated endlessly. There are hooks and eyelets, preformed breakable breaking lines, so you can dilate it to whatever diameter you desire. These are our first patients. You see the stenosis and the late results. This is a very tight stenosis with a good result. This is a more or less hypoplastic arch, which nicely had grown over time. And this finally is Williams-Beuren syndrome, also with a good final result, just implanting a growth stent, no surgery needed in these patients. We also get an immediate good result after implantation. The gradient drops from over 20 to far below 10. There is recently there has been a multi-center publication with this stent, but there's another stent with the same, following the same concept, the B-growth stent from the Bentley company, published by the Swiss group. But despite there are good immediate and late results with those stents, none is available at the moment, and we hope that one of those stents will be admitted to the market within the next years, but we are not sure yet. So the biodegradable stents, there's a publication 4 years ago, first use of the McMurray stent. And they concluded it's a tool to bridge to surgery, because after the degradation of the stent, the stenosis comes back, and we had already proved this 15 years earlier. As if you don't overcome the elastic forces of the stenosis after degradation and the dissolvement of the biodegradable stent, the stenosis will come back and the patient had to go to surgery. So there are two big groups of biodegradable stents, the polylactid-based stents or the metal-based stents. The polylactid have a much longer duration time in the vessel, whereas the metallic stents disappear relatively quickly. There will be new compounds available. There are in the labors right away, and we hope there will be new possibilities with those stents for this patient group. This is just an example how the McMurray stent performed. This is the normal dilation. You can break it relatively easy. If you do it, it looks like this. Even if this looks very uneven, does not cause any trouble because the stent dissolves anyway. This is just an overview of the available biodegradable stents. So for the last chapter, the coronary stent, they are more or less for emergency patients. They have a very low profile. They have a high maneuverability, even for very small children. They have an immediate good result. They can be overdilated only to some extent. And normally you have a wide range of length and diameters available. The maximum diameter, however, is 6 millimeters, and this limits the growth. Surgery becomes necessary in those patients. This is a patient with 1,500 grams body weight with a critical coarctation. We did it using a 3 French short sheath in the groin. For just to define critical coarctation, they are newborns with the appearance of septicemia. They have low cardiac output, have high or rising lactate levels. Immediate reaction is necessary. It's usually it's an emergency procedure. Surgery is critical in this situation. Primary prevention at the cath lab is always the better option. Balloon dilation is an option for short relief, biodegradables with intermediate and stent implantation for a long-lasting benefit. So this is the 1.5 kilogram baby. You see the severe coarctation. And this is a 9 millimeter long, 3.5 millimeter Medtronic driver stent implanted. You see there's still a hypoplastic distal arch, but the patient improved and the patient could be operated on 2 months later. This is how our surgeons resect the stent, and they did an end-to-side anastomosis. Did another patient with 1.2 kilograms, which was done under echo guidance. There was just the implantation filmed with X-ray. No contrast agent was used because the renal function was really bad. And you can see a good result. The stent was exactly in place, and the patient was doing fine. This now is my last patient, as Dr. Krishnamurthy already mentioned. This is a patient born with 660 grams. And we did a first attempt at the age of 12 days, but we could not enter safely the arterial vessels. So there were a second attempt 3 days later at the body weight of 600 grams. It was performed under echo guidance. We did not use sheaths. We just advanced a coronary wire up the aorta. We just checked in X-ray the position of the wire to keep it away from the carotid artery. And then we smoothly advanced the pre-mounted integrity stent through the heel into the artery. And sorry, this is the... And checked the positioning under echo guidance. This was just to measure the length of the stent so that we could be sure that the stent was in proper position. This is the picture before the implantation. This is the picture after the implantation. And we did a recast after 3 months. And the stent is still doing fine. The coarctation was still good, and we did redilation with 5 millimeters, and 4 weeks later the patient was operated on, and there was end-to-side anastomosis performed. The vessel of in the groin stayed open because we had punctured with under echo guidance very carefully and administered a lot of local anesthesia to save the patency of the vessel as good as possible. So I come to my conclusions. Stent implantation shows a longer effect than balloon dilation alone. Biodegradables have a lifetime. Breakables are not available at this time. Untreated, there is a high morbidity and mortality rate in those patients. Critical coarctation is an emergency. Intervention in this setting is better than surgery. Early correction is mandatory. Surgery and interventions, depending on the center's setting, are both an option. Both have setbacks and complications and the need for redos, and do not underestimate coarctation. It's a deadly disease in the end. Thank you very much.
Thank you, Zartner. Dr. Zartner.
Yeah.
Welcome, Professor Shakeel, Dr. Zartner, Dr. Worakan, Dr. Shiva, Dr. Neeraj Awasthi. Please. And Dr. Zartner, one question.
Yeah.
This is very heroic measures of the palliative. Would you consider any babies as contraindication for this procedure in your experience?
You
not suitable?
You asked because of the body weight? No.
No, any conditions you think is not suitable in these babies, newborns? Because generally we consider newborns are surgical, but you are taking up them heroically. Do you think any babies?
If the patient is very stable and your surgeon is able to do surgery on 2.5 kilo. I think under 2.5 kilograms, it's better to do a stent implantation first and to let the baby grow. From 2.5 kilograms on, our surgeons at least feel very easy in doing a corrective surgery.
Thank you.
Peter, I enjoyed your talk, and it was it was nice to know that you have gone down to a weight of 600 grams. I assume it was a carotid access. And what was, did you use a sheath, or you just had a small cut down and you advanced the wire and the stent directly?
We went directly through the skin with a stent, with a pre-mounted stent, and without using a sheath. We are right.
So it was a percutaneous carotid puncture, not a cut down.
It was not a cut down. No, it was echo-guided puncture.
Okay. There was no difficulty in advancing the pre-mounted stent through the skin, subcutaneous tissue, and the vessel wall. It was permitting you to go inside.
No, it was not. No, it was not. It was
Great.
relatively easy. A
Great.
small stitch with a knife, and then it went in relatively smoothly. Yes.
Yeah. Recently, in the PHACES in Chicago, there was a talk on a stent called Renata, which is reasonably popular in different centers in the US. It's made in California. It is also a very low-profile stent, but fortunately, these stents you can deploy at as small as 3 millimeter, but they are capable of post expansion up to 18 to 19 millimeter in adult life. So there's a lot of talk about this stent, and a few centers are now making it. I think probably the next 3 to 4 years we may get more and more gadgets to deal with newborns with this disease.
At the moment, that Renata Mini, it's called, it's not available outside of US because they're doing a multi-center study of implanting it and then seeing if they can redilate and what the results are. So it is potentially going to be a very interesting stent once the study's been completed and once they decide to go outside of US.
Yeah.
Peter, so may I ask a question? Maybe a little, simple, but maybe a little stupid. But in case that you have options, like first you just do balloon in newborns, and second you immediately put the stents in. For the person who not really keen on stenting, will you also considering to do balloon angioplasty instead of the stenting for the first time in newborns?
Yes, at least if the situation of the baby is critical, so critical coarctation, anything you do to reduce the gradient is better than doing nothing. So if I would support any intervention doing balloon if stent is not available or the doctor does not feel well implanting a stent. Yeah.
Worakan, one thing we learned back in the early 90s when we were over enthusiastic about ballooning was that in newborns you could balloon the coarctation, but you have to be prepared for re-stenosis occurring within the first 2 to 3 weeks. So we then started using it as a bailout temporary procedure to improve the ventricular function sufficiently to allow either the surgeons to do something when the baby's condition was improved.
So Shak, in your institution also, do you take up stent angioplasty using the available coronary stent as the first choice rather than trying out an initial balloon?
No, so the first choice is surgery, and so there has to be an exceptional. So there are exceptional cases where we would consider stent implanting, like a really sick baby that's not suitable for surgery. I think that's an important message to give out.
True. In a surgically unfit baby, the first choice will be stenting rather than just a simple balloon.
Correct.
Yeah, that's
Message we have to give that this surgically unfit baby only should have this. Now I invite Dr. Neeraj Awasthi, who has a large experience with stenting coarctation to share his experiences. Dr. Neeraj Awasthi, please.
Thank you, sir. At the outset, I would like to thank Dr. Krishnamurthy and Deepa and the whole team for giving this opportunity to be on those words. So wonderful to see everybody down in the screen. I'll start directly with the interest of time, and I will be talking about the basic topic, coarctation of aorta, stenting step by step. I thought I've been presenting complex coarctation topics before. They were given one or two cases. They were easier. I never realized that simple things can be so complex to present because there are so many things to talk of. As far as true for any case, the first step for coarctation stenting is evaluation. Evaluation because the patient comes to us with various symptoms. We suspect coarctation, and most of the time we have this adult, and we may not have good windows. Showing here. Most of the time, the windows are suboptimal. It is more of a clinical sense which should prevail. On echocardiography, it is not just the arch gradient which is important. We have to look for the acid anomalies, be it a PDA, be it the associated VSD, whatever it is in the aortic valve I'm dealing with. Is there a gradient across the aortic valve which is likely to increase once I open up the distal obstruction, which is the coarctation? What is the transverse arch, descending aorta and the isthmus? And particularly in our scenario, with most of the time, although now as a rule we are doing a CT for almost all the cases, most of the time, in the interest of financial interest, we may not actually do a scan and directly take up the patient onto the cath table for doing a stenting. Of course, the concern most of these cases is the poor imaging of the arch in adults. And in case of concern, it's always a good idea to go for a CT scan. The evaluation of anatomy and the measurements of course are important. The measurements of the stent diameter, the measurement of the stent length, planning as to what approach we are going to use, whether I'm going to use a predominantly a femoral approach or I'm going to take an associated upper limb approach, a brachial and a axillary artery. The length, the size of the diameter of the stent is important. Looking at the adjacent vast structures, is it the subclavian which can get impinged in case I have to use the covered stent? How far is my adjoining structure, such as the carotids, in case I have to use a longer stent? One of the important factors over a period of sterilized is the malalignment between the proximal and the distal segment, as is demonstrated in this particular CT scan. This particular CT scan, you can see there is actually a crooked quark there with a malalignment with the proximal and the distal segment. Most of the time, if we have a malaligned segment, it is not just the true length of the coarctation. Might have to slightly oversize. And actually, before we deploy a stent, always see into maybe two complementary views before we plan particularly this malaligned stents and malaligned quark segments. Of course, we have to look for the associated aneurysms, as has been noted in the next diagram, with where we have a coarctation and associated aneurysm which is there. In the case down, we will be actually stenting this particular. Second most important thing is the counseling, of course. We recently had a 60-year-old geology professor who has lived almost 60 years of now. She said, has been diagnosed with coarctation. She said, do I really need to do something for my coarctation? Albeit in 60 years, you say I've been collateralized. I dissect other animals and I found so much bleeding in the collaterals. Do I really need to do something? Yes, we had a very interesting data, long, very commonly quoted articles which have taken us from the American Heart Journal in 1947. Almost all our fellows are actually have read this also. Of 304 patients, 50% mortality 3 years and 90% mortality over 50 years is there. All sorts of problems may be related to subarachnoid. Interpretation is that we definitely have to do something. And of course, the morbidity and mortality increase as the age increases. Recently, we lost a wife of a cardiologist who had a severe coarctation, who was actually planning it for last years. She was just 35 years of age with the intracranial hemorrhage. So the message is that definitely the morbidity and the mortality increase as the age increases, and it should be tackled as early as possible. Between surgery and angioplasty, the situation is not clear. Previous lecture also, the interpretation is coming more towards a newborn intervention. I'm still taking a very old study, but in grown up, percutaneous option is far better than a surgical option, because surgically going from lateral thoracotomy, dissecting the areas with high of bleeding, and of course the nerve, the chances of nerve injury being high, it is very much important to do to go endocardial, to go inside the lumen percutaneously to tackle such lesions. Balloon angioplasty versus coarctations, the previous discussion also. Whether it's a newborn infant less than 3 months of age, one can use it as a boil out. Of course, the discussion with the previous lecture is, of course, a stenting, which is now coming, new types of stents being coming. Definitely, we are looking for more stentings in near future. From beyond 3 months of age, with relatively stiff structure sitting there, we would rather prefer for actually go for a balloon dilatation. For children, which is definitely a grown-up children, bigger stent can be put, which need not be redilated. There's no discussion, but a stenting is a very good modality. And of course, with more advanced features, all of these factors are modifiable with new advanced stents, which has been discussed in the previous slides. After we have discussed that definitely we need to do something for a coarctation, what about planning? I believe most important step for any coarctation stenting is a vascular access. A beautiful question which was raised by Dr. Sivakumar for the previous case. Small baby, do I have to go from a carotid? So vascular access decided by the site of the narrowing. Is whether I will be able to cross from the femoral artery, or I will have to cross from the maybe brachial or something. Then whether I need to put in a perclose, and if I have to use a close, in that case, probably it's a very good idea to actually do it pre-close before I go in for a stenting. Now we are doing almost pre-close for all the adult stenting, and it is practically femoral in nearly all. And in very rare critical coarctation options, we might have to use the brachial and bare stent is again important question. A beautiful publication by Dr. Shiva in Pediatric Cardiology discusses the decision making in this particular subject. But I would actually summarize by talking of the landing zone. What is the degree of stenosis? How much expansion I need to do? Do I have to go in for more than 5 times the narrowest area? What are the adjusting sections? If I'm
Neeraj, sorry
Yes,
to interrupt. Your slide is still stuck on the planning type of stent. I don't know if you've moved on from that.
Okay. Is it now with type of stent?
I think he's describing the second part now.
Oh, okay,
right.
Okay, right.
Yeah, I'll be talking of the individual case very rapidly in the end. We are talking of the adjacent structures which can get covered, be it subclavian, or there's associated aneurysm. What is the substrate we are dealing with? If you have to use very low profile stent, in our subset of patients, we have a low profile which is available as maybe a Bentley, maybe a better choice whenever you use it, or lower profile stents, of course, the fundamental patient. Planning, the other important step is, of course, to use the stent accessories. I do have need to use additional balloon. What is the type of long sheath I have to use? Most of the time, my support wire is amplats, but at times I need to have a smaller balloon, and I need a 1/4 or a 0.18 wire. In a small child, the dye, the amount, type, and route becomes very important. And in grown-ups, invariably do pacing for the stability of the stents for all our cases. Just to enumerate, this comes with, we actually plan it as to what size of sheath we will be actually using for this particular case. I understand I should get checks because this particular presentation is more for fellows. So I am actually trying to take all the slides, all the important parameters before I go into the individual cases rapidly. In case we have to use a Bentley, definitely we have an advantage of being used covered stent in a lower profile because it is easily available into 6 and 7 7 French, 10 millimeters almost goes to a 7 French, which can easily be post-dilated. Now coming to individual procedure steps. Most important part till now for a coarctation stenting is been the planning. When we talk of steps, the vascular access, always respect the vessel, respect the vascular side, because we will be using a very large French diameter vascular accesses. We use ultrasound accesses for all our vascular accesses, 100%. It's a very good idea to use it for, particularly if you are doing a coarctations. And pre-close preferably. And whenever we have to use a pre-close, we do it when we initially put the initial sheet, which is a 5 or a 6 French sheet. Because once we put in a bigger 10 or a 12 French sheet, we may not be able to use a pre-close. So always good idea to do it at an angulation so that you can use pre-closes. Coming to the steps, the most important steps have already been discussed. These were the planning and the vascular access. Next is, of course, the usual steps. We heparinize the patient, use venous access for a pacing lead, an arterial access, cross the coarctation with the MPA1 with the thermo and a straight wire, take the gradients, and use a pigtail for an angiogram, preferably view. But always try to use in actually two complementary views, an Anleo and Arun. Use the appropriate side pigtail. Nowadays, we are most using more marker pigtails for doing the stuff because it helps in the planning the length of the stent. And of course, two views are always the idea whenever planning for an angiogram. The measurements, the transverse
Neeraj, can we speed up a little?
Yeah, the transverse arch and the aorta are actually a very good idea, and which decide the type of stents that we use. And of course, we have then next comes the use of individual, whether I'm using a pre-covered stent or a covered stent, and how to mount the stents. Crossing it with approximate size access wire. One may actually use the exteriorized thermo wire to move our loop. May deploy the appropriate stent under general anesthesia and expand the stent to the appropriate size. What is generally not needed is to flare the end of the stents and carefully withdraw the balloon expansion under vision, catheter, so that one does not actually, the stent is not stuck to the sheath. I will rapidly go through the 3 index cases. This particular case, I realized that Shaks will actually be talking about these cases much more than us. This was a case where we had almost interrupted aortic. This was actually crossed with the.
We will be hearing about this from Professor Shak.
Yeah.
Can you go to the next one?
Now,
yeah.
Now, most of the time now we end up using CTO wires instead of the hard end as I used in the previous case. This was another interesting case, which was actually a 12-year-old patient who had aneurysm with a severe coarctation. You see, we're trying to cross it descending aorta. We've taken 2 complementary views to define, and you see a very tight coarctation aneurysm there. We thought we have crossed this from the descending aorta, this is the branch, and I think we have crossed from the. That is the important actually seeing in 2 views. We thought we have crossed from the right subclavian artery, but if you start coming in the AP view, we are actually in the descending aorta. So still not actually have crossed it. Again, started the aneurysm, but we realized that the wire would actually keep on in the aneurysm, and we would not be able to cross it. So the aneurysm was causing a lot of trouble. So ultimately, we parked there.
We close this, Dr. Neeraj. We'll hear about this from Professor Shakeel.
Okay, so I'll actually complete my just deployed this stent, and it is a usual course where I tried a covered stent in the final angiogram. Of course, this was the last case in which I would. It's important to see the adjacent structure. There you see a 10-year-old child with adjacent aneurysm. This was the CT scan which was shown initially, and we had to actually cut down and actually a stent graft to cover for the subsequently balloon dilate our graft for the final thing. I'll conclude that coarc stenting should be offered to all the indicated patients. As we've discussed, planning is the most crucial step of the procedure. Possibilities are vascular leak, crossing the lesion, potential complications. The anticipated complications, one has to actually anticipate the complications, and coarctation stenting has definitely got satisfactory guidance. Thank you.
Thank you, Dr. Neeraj. Dr. Shakeel or Dr. Sasikumar, Dr. Worakan, any contribution? Or directly we go to Dr. Shakeel's.
Just one curious question. I saw Neeraj talking about the small B graft, which means the B grafts that are up to 10 millimeter, which will go through a 7 French sheath. Will it not be very difficult to post-dilate these stents? It will be more challenging. I'll be rather happy to use a bare metal stent so that it can be fractured. Whereas if it is a covered stent, it's going to be far more resistant to fracture and get a larger lumen. What is your view, Dr. Shak and Worakan, on use of this particular product in smaller patients?
Worakan, do you want to answer that? Because
for me, I try to use B graft if I have to. Any diameter larger than 10. As Shiva mentioned, that it may be difficult to post dilate up to 15 or 20. So I'm quite doubted if I'm going to use B graft below 10 millimeter. Yeah.
For the participants, just to know, B graft comes in 2 different dimensions. One is up to 10, which are the smaller B grafts. And then the 12, 14, and 16, which are like, they are larger. They are capable of, getting dilated to a much larger diameter, to almost adult size. Whereas these 10 can go to a maximum of 12, I think, according to the company. So it will make it challenging if you use the smaller B grafts.
And the bigger ones are called B graft aortic, I think.
Aortic. Yes.
So there's a slight distinction between the two.
Okay, thank you. We'll go to the next talk. Sir Shakeel will talk on stenting of near-interruption of aorta. What are the tips and tricks from the master interventionist?
All right. So thank you very much for this invitation, and Murthy, well done for setting up this program, and especially in an important topic like coarctation. So I'm going to deal with aortic arch atresia and how to deal with them. These are my disclosures. As you've probably seen already, aortic coarctation is not a simple lesion. There's a lot of morphologies to deal with. There's a discrete coarctation. You can have a long segment coarctation. You can have associated transverse arch hyperplasia, tortuous aorta, where there is malalignment between the proximal and the distal aorta, and then the extreme form, aortic arch atresia. Now, in adults that we're dealing with, atresia of the aortic arch is usually acquired. That's entirely different from newborn babies with aortic arch interruption or atretic arch. In the adults, there is a potential continuity between the isthmus and descending aorta, and that continuity or the patency may vary from a localized membrane to a very long segment, as you can see in these pictures here. In these adults, adolescents, surgery is challenging, and there may be complications such as paraplegia, post-coarctectomy syndrome, paradoxical hypertension, and recurrent laryngeal nerve palsy. And so the surgeons are not always keen to deal with these in adults, and therefore catheter interventions have an important role to play. For these, we need a covered stent, but usually you have to make a way through by perforating this interruption before you can put a covered stent in, and that's what I'm going to address. So what are the pieces of equipment that you need for dealing with arch interruption? Well, coronary guide wires, and you can have your own choice of 0.014-inch guide wires, Asahi, run through, but it's a personal preference usually. I tend to use Asahi, the medium load in particular. Transeptal puncture needle kit. Occasionally, you have to use a transeptal needle to puncture the interruption. Radio frequency perforation kit, Baylis generator and wire, Nikken and wire, has occasional use because you have to burn a way through. Long Mullins sheath, or nowadays, if they're not available in some countries, then the equivalent or similar sheaths may be appropriate, 12 to 16 French. Various sizes of Taishak, Z-Med, VAX2, or other similar balloons, and covered stents of different lengths, such as from the NewMed CP stents, B-graft that we've mentioned, and Optimus covered stents. CP stents, well, they're available and have been available for quite a long time. They're made of platinum and therefore they're MRI compatible. They have rounded, very nice rounded edges rather than sharp edges, and therefore less likelihood of balloon perforation. They're either unmounted and therefore hand gripped or pre-mounted, depending on what your requirements are. They come in different lengths from 22 millimeters up to 45 millimeters. The 8 zig, so-called Zs or zigs in a row, these can be dilated up to 22 millimeters, but anything bigger than that, you then have to have custom-made 10 zig stents, which can be custom-made in length as well. They're slightly higher profile because of their manufacturing technique, and so you may need anything up to 14 French or even 16 French, depending on your initial balloon size and stent assembly. The pre-mounted ones are also available as so-called New-Del system. That's the aortic stent system. It's a bit like the Melody valve. So the covered stent is implanted positioned on the balloon and then covered with the sheath over it. And these are available from 12 to 24 millimeter diameter with the profile of 12 to 24 French. And these are specifically for aortic coarctation and atresia. Now, what about the technique itself? Well, we usually recommend radial and femoral artery access. And then there's a rough rule, and that is that if the descending aorta is larger than the proximal arch, then we attempt perforation from above. And if the proximal arch is bigger than the descending aorta, then we perforate from below. We usually attempt perforation with the soft end of the coronary wire because a lot of the time, if it's a short atresia segment, then there is a way through, and you can usually get a clue from the presence of a little dimple, as you can see, or may be able to see on this picture. Now, if the soft end of the coronary wire fails, or a Truma wire, then you can try the stiff end of the guide wire, but that's not the first choice. Transeptal needle, again, that's not the first choice. And radiofrequency wire perforation if all else fails. Now, if you're perforating from below, and let's say, for the sake of argument, you're using a transeptal needle and you've got through, then it's best to replace or put a coronary guide wire through the needle into the isthmus or transverse arch before you advance the catheter or sheath across, because you want to make sure that your guide wire or the perforation is into the vessel rather than outside, and I'll come back to that. If you're perforating from above and you think you're in the descending aorta, then it's best to snare from below, establish a circuit, swap the wire over to the appropriate one for the sheath, and then advance Mullins sheath or equivalent from the femoral artery approach. And then, of course, covered CP stents or whichever stent you want to use on balloons. Here are some examples. You can see here, this is not really interruption. There's a tiny way through in this aortogram that you can see on the lateral projection or LAO projection. There's a little jet going through. And so in this case, we use a soft end of the coronary wire and carefully advance it and see whether you can see it well enough to make sure that it's in the vascular system. And in this example, we then established a guide wire system from the right radial artery, and then over that circuit, you can see the catheter from the descending aorta being pushed from below into the transverse arch. And then once that catheter is through, then you can change the wire and then change for a pigtail catheter for better angiograms. And then the appropriate covered stent can be implanted. And in this example, there's adequate length between the left subclavian and the coarctation, so there's no fear of covering the origin of the subclavian. Now, in this example, there's again, probably atretic segment, and so you then have to work out whether you want to approach from below or from above. In this case, we approached it from above, got the wire into the descending aorta, and then if this plays, the wire in the descending aorta was snared from below, arteriovenous guide, arterial guide wire circuit established, and then sheath advanced, and then you can see the appropriate sized covered stent advanced above. This was the example I showed you earlier, and from a radial artery approach, a pigtail angio shows no way through. So in this example, we attempted with a soft end coronary wire from above, and you can see once it was through, the guide wire was snared in the descending aorta, which allowed you to push the catheter from above into the descending aorta. And once it's snared, you can establish an arterial guide wire circuit, change the wire over to 035, and then advance the Mullins sheath up into above the coarctation and do some check angiograms. Once that is in place, then of course you carry on with implanting a covered stent, in this case a covered CP stent. Again, there's no issue with the left subclavian artery, so a bib balloon is used, and there with the final inflation and the final angiograms showing a very good result. If you've got a proper atretic segment, as this case, you can either approach, because the vessels are similar size, you can either perforate from above or below. In this case, we perforated the soft end of the wire was not getting through, so we used a stiff end of the coronary wire, and you can see that as at the bottom left, you can see that it's in the transverse arch, but you have to check with some angiograms to make sure it's in the transverse arch. And once you can see that, it's very difficult to see the stiff end here, but that confirmed that it was in the descending aorta. Then you can maneuver catheters from below into the proximal part, swap the wire over for 035 wire, and then advance the sheath, and then position your covered stent, and you can see here the final inflation result. Now, there will be some cases where origin of the left subclavian artery may be covered, and so one of our rough rules is that if the left subclavian artery is larger than the left common carotid, then the circle of Willis may be relying on supply from left subclavian, and therefore covering it should be avoided. If the left subclavian artery origin is covered, then you have to have strategies to open that. So you can either perforate the covering into the left subclavian from above or below, but usually from above we have left radial artery access, or there will be alternative techniques to avoid. I'm grateful to Nageshwar. We did this case well before COVID, long time ago, and you can see this is an atretic coarctation. Left subclavian artery is really very close to the atretic segment. In this case, we attempted perforation from above, and we thought the wire, stiff end of the wire, was in the aorta, but you can see here that it's probably in the in the wall of the aorta rather than in the lumen, and therefore we avoided pushing the catheter from above over the wire into the descending aorta. We attempted perforation from below, and again from a stiff end of the guide wire, and on check angios you can see that this is unlikely to be in the vessel as well. So we attempted a few more perforations. Again, each time the stiff end of the wire was going in outside, and so the key lesson there is avoid pushing the catheter until you're absolutely sure that the wire is in the lumen. Here, from the bottom, from the descending aorta, stiff end of the wire was pushed into the transverse arch, and you can see that we've snared it. That allows the catheter to be pulled through. Then you can swap the guide wire over for a 035. That allows you to push the sheath through. Now, of course, having got the sheath through, we have to work out a strategy to avoid occluding the left subclavian artery. And this is where Mark Gavilik's double balloon, double wire technique is very useful, where we put two wires in place, mount the stent over two balloons, and then advance these from the femoral artery. Just as a rough rule, here you see there are two balloons, Taishak ones, 110 and 112. That gets you a total of 22 millimeters. 80% of that is around 18, 19 millimeters, and therefore that would give you that sort of choice. The two balloons have a profile of 10 French, so you could potentially, with a covered stent implanted, just about get away with 11 French, but safer to use a 12 French sheath to allow that. Here's an actual picture of two balloons with a stent mounting on the two balloons over the two guide wires, and then you work out what French sheath will be required. Just some more pictures of the mounting of two balloons. Once we're there, you see here from the sheath, we've pushed one guide wire into the left subclavian, the other wire is in the right, and then the two balloons with the stent mounted on them are pushed up, and you'll reach a stage where the balloon in the left subclavian prevents the covered stent from pushing further up, and therefore you can inflate the balloons there, and you see that the top end of the stent is opening into the left subclavian artery. Once you're in a good position, you can uncover or withdraw the sheath and then carry out the full inflation, and there you can see that the atretic segment is now widely patent. The left subclavian artery is also widely patent. So to conclude, in adolescents and adults, catheter intervention is really preferable to surgery for these aortic arch atresia patients. Approach can be from above or below. Radial artery access, usually the right, but occasionally the left is essential. Perforation can be from the soft end or the stiff end of the wire, or transeptal needle or radiofrequency wire. Snaring is usually needed, whether it's above or below, and you need a really good supply of covered stents to manage these patients. I'll stop there. Thank you very much.
Thank you, Sir Shakeel. Now, Dr. Shiva, Dr. Promphan, or Dr. Zartner, any contributions from your side?
Shak, as always, thank you indeed. A very, very fascinating talk. Just a technical question, that once you get the wire into that atretic area, will you recommend to do like pre-dilation with smaller balloon, or just passing the sheath in immediately? And what is the reason, please?
So you can use, if you want to pre-dilate, but once we've got an arterial guide wire circuit, you can easily, as long as you fix both ends of the wire, you can pull, depending on which catheter you're pulling, you can pull through the coarctation area fairly easily. And once you've got the catheter through, you change to a stiffer wire, then the Mullins sheath or the equivalent can also be pulled through over the circuit. So we don't pre-dilate, because occasionally, my theory was that if you pre-dilate and it's an atretic segment, you might be outside the atretic part for a few millimeters anyway, and then you might have some extraneous bleeding as well. So we tend to just make sure there is a catheter or a sheath across that perforated segment.
Shak, I enjoyed your talk as usual. There are quite many tips to take from in the talk. My one question is, I'm very scared of using the Taishak balloon. You were mentioning about two Taishak balloons, 10 and 12, with the covered stent mounted all around it. The fear for me is that if suppose the Taishak just breaks the moment we start to little bit dilate, and then you'll be stuck with the stent that is not expanded, and you have two wires going, one here, one there. Then it makes it very difficult to deal with that situation. So do you feel Taishak balloon is good enough for this?
No.
Or
So I was only using that as one example, because we've got other balloons that are higher pressure. So advanced balloons from Cook, they're quite useful. It's really having appropriate diameter, whether it's 10 millimeters or 12 millimeters of low enough profile, because if you use a higher profile, then you're going to finish up with a larger Mullins sheath or equivalent sheath. And so it's a matter of working out which would be the lower profile. So whatever balloon, if you've got VAX2, if you've got ZMed, that's fine, as long as it doesn't increase your sheath profile. So I'm not advocating 2 TISHACs as the routine. It's really whatever, but we've used them. And if you're using a CP stent, it's got rounded edges. It's less likely to perforate the balloons. If you use other stents which have got slightly sharper ends, then there is that potential risk.
This is a question.
Is balloon in balloon needed for all cases? A question from the audience. Sir Shakeel.
So I presumably you're talking about the bib balloon. Well, the answer is not all cases. We, in atretic coarctations, you can use normal balloon of the appropriate diameter. You then have to be just careful and do frequent angiograms that you're in correct position with your stent, because in an atretic segment, if you half inflate or more than half inflate and then try and adjust your position, it would be difficult. So it just needs extra care in terms of positioning of the stent and then final inflation. So you don't need a bib balloon as such, but it gives, the bib balloon gives you 50% the diameter of the ultimate diameter. But you know, again, I'm not that dogmatic about it. I'm flexible.
In continuation with the question on balloon, Shak's Kumar Worakan, any experience non-compliant, using a non-compliant balloon in that area? Any maybe an atlas? Has there been a subset where that has been used? Not on semi-compliant balloon, non-compliant balloon is atlas, which is used in any form of caution. Any subset of patients where it may be needed.
So we haven't.
Shiva,
Shiva, do you want to answer that?
Shak, I actually advocate not to use an atlas balloon at all for coarctations. But the reality in India, in different peripheral centers, there is non-availability of different sizes of ZMed balloon. As well, ZMed is almost twice as expensive as an Atlas Gold. So I'm finding that in the peripheries, quite a lot of operators do use an Atlas Gold and sometimes use that as their primary balloon of choice for a coarctation. I have never done a single patient coarctation with using Atlas balloon at all. I have post-dilated with an Atlas, but never used it as a primary balloon for mounting a stent.
Yeah,
yes,
I agree with that. And
shall we go to the next talk?
No, I think the point Neeraj is raising is very important, because I think in the participants there will be a large number of audience who may be using Atlas, and I think just allow one minute more for this particular. Peter, what is your opinion about using Atlas, and Worakan, your views too?
We do not use Atlas in coarctation either. So because I think it's you do not have a good sensor for what you do with the vessel. You can go up to very high pressures, and the balloon does not adapt very well to the vessel wall, and you do not see what you are really doing. So I think the Atlas in coarctation can be quite dangerous. And the other thing, using it for stent implantation, it's very slippery outside if in the vessel. So we don't use it. Don't use it for deploying stents in the coarctation.
Worakan, brief.
Yeah, I agree with Peter. It's slippery balloon. I think at last, so I won't mount it with the stent. And also initially we don't need a high pressure. I do mostly post-dilating after we implanted the stent, and then, we want to make it bigger later on.
Thank you. Yep. Now we will welcome Dr. Promphan for his talk on complications.
Thank you, sir. So my pleasure to be here amongst the expert, from around the world, and also experts from India. Thank you much indeed for this opportunity. So this is my disclosure. I have none of that related to this talk. When we talk about complications of coarctation intervention, generally we're gonna deal with the aortic wall complication. We're gonna deal with the peripheral vessel complication and also the stent complication. Just to share with you that for the stent, it could migrate, it could fracture, could have like a balloon rupture, or they may have like future intra-stent proliferation, restenosis, or even stent collapse. But I'll tackle some of that later on. But just to share with you that we use the stent in order to trying to avoid dissection or aneurysmal formation or uncontrolled tear. So these are the thing that we should consider when we try to deal with the coarctation. So as the general rules, I think for all of us, prevention is better than cure. So we know exactly that balloon dilatation, having a uncontrolled or less controllable complication compared to put a stenting in. So that was meta-analysis, since 2016. And just recently published showing the same, that if you can choose, you should try to deal with the stenting in native coarctation rather than try balloon dilatation only. But recoarctation still controversial because the data is not showing the superior effect of coarc stenting at the first place of the recoarctation. So stent design, of course, you have two things, open cells or closed cells. I'm not sure about what you have in India, but in Thailand now, Genesis, we do have, but very, very uncommonly used. CP stent, we still having it. Mega LD, Maxi LD, we don't have it anymore. We do have Andra stent, which is quite limited. We don't have formula value out of the market now, and B-graft aortic, our working horse for the cover open cell design stents. I think previous speakers did approach to this, but just to confirm that when you deal with severe long tubular or complex anatomy or associated with PDA or having previous dissection, rupture, aneurysm, so those things are quite useful, to deal with the complication. Turner syndrome is one of the things that you may need to consider because the aortic wall is quite fragile, and sometimes you never know what will happen older age, because again the vessel may not be as young as the adolescent patient, so you may run the risk of complication. Neeraj did mention this, but just emphasize that starting with the puncture, you need to make sure that you have a good landing zone. I mean, in terms of the puncture, I personally use the anatomical landmark. I mean, use the groin palpation, check ASIS, pubic symphysis, where's the inguinal canal, and then I confirm with the ultrasound guided. And also, most of the time, I need to make sure that my puncture is at the middle part of the head of femur. As you can see here, that it's above the bifurcation here of the femoral artery. And also you need to check the angio before the procedure, because that's important. You need to make sure the size of the vessel that you're gonna deal with, and sometimes you may get spasm of the vessel. So make sure that you treat the vessel well before you engage that kind of vessel with a bigger sheet like 12 or 14 French in adult. And after that, you may deal with the very complex anatomy like this. A visual tortuosity is one of the things that you may appreciate, that your stent need to be very good in terms of flexibility. So that can help you a lot, to concave or to appose properly in such a way that the vessel wall is behaved. And just to confirm again, previously mentioned by us, that if we start with the B-graft aortic 12 or 14 millimeter, most of the time you can post-dilate it up to 20 millimeter, which is enough for Asian people like us. So as you can see here, immediate procedure looks like this. 1 year post, it's getting more tortuous. and also there's a gradient. So that's why we came up, went back again into the cath lab, put a bigger Atlas Go balloon to post-dilate it. And as you can see that the size is getting bigger and functioning of the cover stent. And this is a thing also, maybe the next speaker will also show some demonstration, but this is another opportunity that we can use the cover stent to deal with the coarctation which associated with the ductus arteriosus. And as you can see, here's quite long segment coarctation, small descending aorta, and also very small isthmus here, and eventually has been managed properly by putting one cover stent. How about residual coarctation? So this is a thing, thanks Super and her team allow me to be involving. So this patient has been actually stented a few years ago, but somehow there's a kink on the aortic wall between the second, the third, and also the coarctation stent. So that causing some residual coarctation. So in this particular case, we eventually trying to manage that by putting the stent. Actually, we don't really need a B graft in this particular case, but it's pre-mounted and it's more, controllable in terms of the positioning. So we get used to that. So we went with the B graft stent. But just to share with you that once we implant the stent, because of the tip of the guide wire is heading towards the aortic arch, so it means that somehow the distal end of the stent is not properly opposed or properly flare in such a way that it will may not causing a good flow here. So we just rail the wire to the subclavian artery and using the same balloon to just a little shape the distal arch stent. Distal stent to conform better to the anatomy. It is not a double balloon technique as Shaq mentioned, but this is just the same balloon, but trying to just opposing the distal part of the stent to get in the right position, just like this. So here's the before and after procedure, and you can see that it's kink here, and eventually managed properly by putting another stent covering this area and also post better to the wall of the vessel. And how about recurring coarctation? So this is a thing that sometimes we need to come and treat the patient after a surgical procedure. Again, this is the patient post coarc repair, end-to-end arch arthroplasty with a xenograft patch in newborn period. It is a Turner syndrome. So our worry that time was, the fragility of this vessel wall, and as you can see here also that as Shaq mentioned that in this particular case, subclavian artery on the left side somehow slightly smaller than the carotid artery, but we are quite concerned whether if you're going to put a stent here, of course it may cause an issue if somehow it blocked the flow there, but we are not quite comfortable to use the bare stent. So we went ahead with the covered B graft, and as you can see here, it's we intentionally gel the subclavian artery because we don't want a complication around this area to create having it, in a Turner syndrome patient like that. So we use 14 millimeter B graft and eventually post dilated. Hang on. Let me. Okay. Yeah. So we post dilated with the same balloon, but using at the nominal pressure, just to make sure that we get the proper diameter. And as you can see, it's recoiled back a little bit, but that's acceptable for us. And after that, because it's gel the left subclavian artery, So we decided to go from the left radial artery and then try to use the stiff end of the 014 Conquest Pro. Sorry for the quality of the image, may not be really good enough to show, but trust me that the stiff end of the Conquest Pro coronary guide wire has been perforated perpendicularly through the stent. And after that, we exchange to the soft end of the same coronary guide wire. There. Then we just follow by the using small coronary balloon catheter, followed by exchanging to the 035 rose and white, and then eventually came up with the balloon 6 millimeter Admiral balloon in order to open up the place where the subclavian artery has been gelled. So we didn't want to destroy the stent here, because you can see it's very close to the distal part of the stent. So we won't try to manage to make that hole bigger than that. And this is the final result. Sorry for not very clear, showing that how the patency of this is immediately. But echo-wise looks fine, and also from the CT imaging 1 month post, it looks as if we got very good flow to the subclavian artery on the left side. And also, when we deal with the aortic dissection, of course, cover stent can be very useful. I'm sorry that this cannot be run properly. Oh, there. So here you can see that there is a dissection after we implant the CP stent here. So with that, we need to somehow, covering it by
I request you to speed up.
CP stent. Yes. So every day may not be a good day, I would say. So this is one of the patients that haunting me for years, and until now, you can see near-interrupted coarctation of aorta, Turner syndrome, systemic hypertension, 36 years old. So so that time we thought we use a cover stent should be okay and should be like sealing everything, but actually it's not. You can appreciate that there was a very huge dissection from here down to the femoral, down to the descending aorta. So with that, we try our best that time to put a cover stent above and below. So we eventually put 5 stents, but unfortunately, we could not manage to seal everything completely. But that time, that was the best option that we can provide for the patient. Well, eventually this patient passed away 3 years after the procedure, even if we try our best, because the surgeon also could not help this patient out by a very huge dissection like that. So it doesn't mean that cover stent can hold and can seal everything. It is not like that. So please bear in mind. But of course, there's something good in every day. So this is a case that to be quick. This is very interrupted, nearly interrupted segment here, bypassed years ago, but having some residual gradients there. So we eventually went ahead with putting cover stent. But as you can see here, while we're trying to advancing the sheath to get the pressure gradient. Oh, I think that this is the thing that take-home message for you, that this is not a good way to do. So be careful when that, especially the B graft, because the B graft, the open cell is very fragile here, and even if it's covered there outside, but you run the risk of injury of that. Immediate result was fine. There is nothing here, but just to share with you that 1 year later, you can see this look like a pseudo-aneurysm is coming here. So eventually we need to came back and put another cover set there. So if you intimately tear the cover part of the stent, so be careful. I think it's better way to do it on that day of the injury rather than leaving and causing the long-term complication like this. And last but not least, just to share with you, but sometimes you may deal with the difficulties on the femoral artery complication, like this particular case. You have like pseudo-aneurysm coming from the femoral artery, and having like a big aneurysm there. So with this, this is a case that eventually managed to be like completely sealed with that aneurysm by just compressing the aneurysm by ultrasound guided for 45 minutes. And then eventually we can manage that complication. So in conclusions, ladies and gentlemen, many of complications of coarse stenting is avoidable, but you need to pay attention to all the details, be meticulous to all steps, invest enough for your cath lab and teams, and use cover stent when needed. But again, it's not always avoidable, so you need to have a plan B. Thank you very much indeed.
Thank you, Dr. Promphan. Now it's open to panelists for comments. Sir Shakeel, Shiva, Neeraj, and Dr. Zartner.
Well, Worakan has shown some excellent examples, but also the important message is for these complications, it's no good just having one covered stent to bail you out, because sometimes you need more than one, anything up to 4 or 5. So equipment is very important. Coarctation treatment should not really be taken very lightly.
Yeah, it was an excellent talk, Worakan. I think you covered all the precautions that an operator has to take into account before this procedure.
So wonderful talk as always, and such a delight to hear Dr. Worakan. Thank you.
Thanks,
just
Neeraj.
a few questions. Suppose on table I detect a stent fracture in a bare stent. Would I always go for a covered stent? What will be indication to use a covered stent if I detect by last angiogram which showed a partial stent fracture? What substrate I will be using covered?
I'm not sure that I understand your question correctly, because your sound is like comes and goes. So can you repeat that question again, please?
Yeah. So would you use a covered stent for all cases? Instant stent fracture, or you have what substrate you are going to use the covered stent? You have to use in case you have a stent fracture on table.
Okay, so if you have stent fracture, of course, I will definitely use copper stent, because I'm not quite sure whether that kind of fracturing segment may, when I post dilate it, it may injure more to the vessel wall. So just to be on the safe side, but as I said, it's not 100% guarantee that you will not have a problem. So my choice to be copper stent. I'm not sure about others. Shiva, Shak, what do you think?
Yeah, if there is a fractured stent, it will be safer to use a covered stent, because the fractured ends may poke into the wall without any control at all. I think it will be a definite indication for using a covered stent.
So in the interest of time, we'll wind up session. And thank you for all the speakers. Now I invite Dr. Shiva to moderate the next session, and the panelists will be Sir Shak, Dr. Zartner, Dr. Promphan, Dr. Neeraj.
Yeah, thank you, Dr. Krishnamurthy. I think it was a wonderful meeting, and we are already running 20 minutes late. There are some 7 interesting case presentations. May request Dr. Vinothkumar from Chandigarh to give his first presentation, a newborn coarctation.
Each presentation will be 5 minutes and 5 minutes discussion.
Good evening, sir. I want to thank everyone for giving this opportunity to participate among these great panelists. And certainly, an interesting case an infant who was presented with 28 days of age, who is born at a term with birth rate is 2.3 kg, without any other perinatal events. He was presented with 28 days of postnatal life with distress and shock and reduced urine output, lethargy for the past 3 days of duration. On presentation, the child was in full-blown shock, pulses were not taken, and cardiovascular examination revealed 3/6 systolic murmur at the aortic area, and also his sepsis markers were positive. Blood gas showed severe metabolic acidosis, and he was initially resuscitated with fluids on inotropes and ventilation. Considering the shock, he was started on PG1 because unresponsive. His ECMO showed bicuspid aortic valve with severe AS with gradient of 54 and 30 millimeter of mercury, and severe coarctation with gradient of 36 with severe LV dysfunction with a ejection fraction of 20%. CT also confirmed the presence of severe coarctation. Considering the mixed management we have discussed regarding the primary surgery versus hybrid versus percutaneous palliative procedure, considering the high risk for surgery, the child was taken for palliative balloon dilatation. So in the general anesthesia, USG guided, we had tried to access the femoral artery, but it went both bilateral access we couldn't get, so it went unsuccessful. So hence, as the echo showed PF4, we have revised, we got the venous access of femoral artery, femoral vein. So we have revised our plan to go through the transvenous approach, so balloon dilatation, and with the JR. We had crossed the PF4, which was the Thejaswi injection showed the presence of high PF4, which is crossed with JR and thermo wire. And the LV angio showed severe aortic stenosis with severe coarctation, post subclavian, around 1 centimeter below the subclavian artery, with diameter of 2 mm, and BT at national was 4.5 mm. So with that, initially we had stabilized the JR guide across the mitral valve to coronary wire. Though we could able to successfully dilate the aortic valve with 420 mini Tyshak and 4.5 coronary balloon, we couldn't cross it with a single wire across the coarctation segment. So we use a buddy wire technique to cross the coarctation segment. For dilated with 420 mini Tyshak and 4.5 coronary balloon. So here is the end result of this transvenous balloon dilatation. Balloon dilatation, we had a severe LV dysfunction with AS gradient of 48 and coarctation gradient of 36. Post balloon dilatation, AS gradient which was reduced to 18 and coarctation gradient which was reduced to 8 with good antegrade flow. So from this case, in such sick neonates, we can consider transvenous approach because in the presence of PF4, it is feasible to go through the transvenous alone in such sick neonates. So the combination of severe AS and coarctation is rare. We can consider so in such sick cases.
Thank you very much, Vinod. It was an excellent patient, and I think you have highlighted the difficulties in getting a femoral arterial access in a patient who is with shock and the severe coarctation. I think, Dr. Shaka, this is an interesting area. One of the problems about this transvenous approach is that the guide wire, if it goes through the anterolateral papillary muscles of the mitral valve, and then the balloon goes in, sometimes we recognize post-procedure that there is a mitral valve injury, caudal injury with some mitral regurgitation. Any tips how to avoid such a thing happening?
Well, this is a really complex problem, and you've highlighted some of the issues. So if you go backwards or working backwards, we would have almost certainly gone from a carotid approach for both the aortic valve and the coarctation if the patient was unsuitable for conventional methods. But if you're going from femoral venous approach, again, weight is the key. You can use a balloon wedge catheter if you have them available nowadays, and see if you can float it through the mitral valve and up into the aorta. Otherwise, it's occasionally, a lot of the time, it's hit or miss as to whether you're going through the coda or you're clear of them.
Yeah. So second thing is, while we should, it's not very predictable to say whether the balloon will cross. Sometimes it might get hit against the lateral wall of the left ventricle, and especially in a patient who is having LV dysfunction, who may have some sort of a spongiform myocardium, it sometimes we may find it. Actually, we recently had an experience of the same thing, disease in an 800 or 850 gram baby who had very severe coarctation, we electively decided to go transvenous. In that, we try to avoid mitral valve injury by taking an extremely floppy coronary wire, like a run-through wire, just made it float within the mitral valve and made it turn around. And then we also did the sort of similar procedure. I think it's Vinod, your point was very good. Any point, Worakan or Peter, on this?
Well, for me, no. Congratulations. I think this is a very challenging case, and but just to ask whether how does the coarctation behaves after the procedure, like 1 or 2 months later, or just recently did this patient?
What is the follow-up, Vinod?
Sir, so the baby was quite well post procedure, sir, but we couldn't able to revive the baby because of suture, sir. Suture week, the baby second because of.
How many months after the procedure now?
Sir, 2 weeks.
What, just 2 weeks? Yeah. In our case, Worakan, the 800-gram baby, which we did a balloon dilatation, some fortunate baby. The baby is at, maybe we just saw yesterday at 8 months, the child is having no recoarctation. It's just a very, it just happens. It's not. I think the chances of recoarctation is extremely high in these newborn babies.
Yeah.
Peter, any points to take?
Yeah, 20 years ago, we used, as Jacques already pointed out, we used wedge catheters to make a turn in the left ventricle, and that made things much easier. And we did Antegrade aortic valve dilation. But with a smaller size, smaller balloon profiles, we go retrograde today. But in fact, the wedge balloon is the option to go smoothly through the ventricle.
Yeah. Thank you very much, Vinod. That was a wonderful talk. The next speaker will be Dr. Gousia Mukhtar from Sri Chitra Trivandrum. Gousia has been with the pediatric department for quite a long time in Chitra. Over to you, Dr. Gousia.
Good evening, everyone. I'm presenting this case of a 13-year-old girl who presented to us in infancy with heart failure. On examination, she was found to have a sternal cleft and multiple hemangiomas in the periodal region and the trunk. She was found to have a hypoplastic aortic arch, an absent right brachiocephalic and left common carotid, a patent ductus arteriosus with shunting left to right, a pre-subclavian severe coarctation with origin stenosis of left subclavian, but that was confirmed by cardiac catheterization. So as this left subclavian was arising from the coarctation segment, and the left vertebral artery from the left subclavian was an important source of cerebral blood supply, she just underwent a pericardial patch aortoplasty of the coarctation segment with duct ligation at 15 months of age, followed by a sternal cleft repair. Following this, she improved, but at 8 years of age, she was noted to have severe recoarctation. Then she was lost to follow-up, and we again saw her at 13 years of age. At this time, we planned the stenting of this pre-subclavian transverse arch coarctation. So the brain circulation was assessed pre-procedure, and we saw that the left vertebral, the intracranial circulation was supplied by the left vertebral artery from the left subclavian. And as we are seeing in this brain angiogram, that there was a collateral that was arising from the DTA, and it was going up and forming a plexus of vessels in front of the first rib. And distally, it was reforming a small caliber right internal carotid and right subclavian. The left common carotid, as we can see, it was absent. The MRI brain, the brain perfusion map also showed predominant green and blue areas, indicating reduced cerebral perfusion, but there were no chronic ischemic changes. As we were concerned that even balloon dilatation across the coarctation would compromise the brain circulation, the intra-procedural cerebral neuroprotection was planned with therapeutic hypothermia, mannitol, and thiopentone. The hypothermia decreases the overall cerebral metabolism. Mannitol decreases the cerebral perfusion pressure. That would decrease the overall, that will preserve the cerebral perfusion, and thiopentone decreases the cerebral metabolism. So we planned an uncovered stent, an 6 centimeter uncovered CP stent was mounted on a 14 millimeter cross 60 millimeter Z-med balloon based on the diameter of the transverse arch. Post deployment, there was a residual gradient of 20 that was post dilated with 60 millimeter and cross 40 millimeter Z-med balloon, following which there was no residual gradient. And as we are seeing in this angiogram, the flow into the left subclavian was preserved. And on the recent follow-up, she is doing very well 7 years post-procedure. There is no gradient in the upper limb and lower limb, no upper limb hypertension. And the right upper limb shows reduced blood pressure due to the small caliber internal, the right subclavian was small in caliber. The stent is flowing well. And in fact, she has recently delivered a healthy baby boy after an uncomplicated delivery. So the learning points from this case will be that the coarctation in PHACES syndrome is often complex and associated with diffuse arthropathy, and intraprocedural cerebral neuroprotection is of paramount importance in our stenting with compromised brain circulation. Thank you.
Thank you, Dr. Gousia. It was a phenomenal patient. I think it shows many things that just a left vertebral artery alone is enough for maintaining whole cerebral circulation for like as long as say 20, 30 years of age. That's an excellent thing. I mean, it was a case extremely well managed. But one thing that I'm not able to comprehend well is the balloon inflation and balloon deflation that is happening during a coarctation stenting is for few seconds. And does that need really a cerebral protection? I do agree that the patient is going to have something like a syncope during those 15 or 20 seconds. But that's going to get out the moment that you deflate the balloon. So do we really need a therapeutic hypothermia, thiopentone? Since you have given general anesthesia and you have made the patient not be aware of the syncope, it's a matter of 15 to 20 seconds, you are going to be deflating the balloon. So really, do you need the strategies of cerebral protection? I'm not able to really understand. But I think your concept is good. A brief period of very transient cerebral ischemia. What is your thought, Dr. Shak and Peter?
I agree with your comments about the duration of inflation and syncope. But the other thing, unless I missed it, the other thing I was trying to understand was was this a covered stent?
No, uncovered.
That's why the left subclavian flow is maintained.
Yeah.
Okay. Yeah. Because I was more concerned that if there was a complication such as dissection with the bare stent, then what would be the backup plan? Because it's a tough one.
Yeah, it's very tough. It's tough to imagine even what will be the backup plan.
Yeah.
This being one of the most complicated cases in a child, we didn't want to take any risk. That's why we opted for this neurocerebral protection.
Yeah.
Shiva, Shak, Peter. So I'm thinking if in this particular case, if we don't have a backup plan, so how about surgical bypass? Should we consider this as a first choice?
I mean, so bypass means what? Ascending aorta to descending aorta, jump graft now?
Yeah, something like that.
It's going to be, again, very challenging. We have already dissected this patient through a left thoracotomy. So there's going to be a lot of additions. Ascending aorta is intrapericardial and descending aorta is extrapericardial. Now, I think it will be very challenging for the surgeon also to get a ascending to descending jump graft. Peter, what are your views?
As you said, it's very challenging for the surgeons. I know only 2 patients having a jump graft from the ascending to the descending. The connection to the descending aorta was put very low at the height of the diaphragm. So it was a big cut in the front and a long bypass. And one patient was Williams-Borden syndrome, and he anyway received lots of stents afterwards to make the aorta grow. So it's, I think it would be possible, would be a solution in this case, because ascending and descending aorta are nearly equal sized.
Yeah. I mean, it was a phenomenal case, Gousia. I think we appreciate you for bringing such a complex. Many people would not have seen such a patient who is living only on left vertebral artery. I would like to request the third speaker, Dr. Ananya Shetty from Jayadeva Hospital, Bangalore, for yet another interesting case.
Good evening, everyone. So myself, Dr. Ananya, I'm from pediatric resident from Jayadeva Institute of Cardiovascular Science Research, Bangalore. So today I'll be presenting a case of transcatheter management of coarctation of aorta associated with PDA. So I have a case who is currently 1 year and 2 months, who first visited our hospital at 2 months of age. This child was born late preterm with a birth weight of 1.8 kg and was referred to us for evaluation of failure to gain weight and symptoms of heart failure. On examination, child was tachypneic, tachycardic, and had short systolic murmur in the left upper sternal border. And echo revealed dilated all 4 chambers, and there was a large PDA which measured 5 millimeters and was predominantly shunting left to right. Also, there was severe PH. Child had bicuspid aortic valve, no AS or AR, left arch with prominent posterior ductal shelf, but no coarctation. So in this ductal view, we can see a large PDA which is shunting predominantly left to right. So the child was started on diuretics and was planned for transcatheter PDA device closure. So the procedure details was, the pressure data during the procedure was as follows. The PA pressure, as we can see, there is equalization of the diastolic pressure and the systolic pressure is more than 2/3 systemic. The PDA was closed using a 10-8 LifeTech PDA device from the transvenous axis, and post-procedure, the PA pressure dropped to 38 by 14 millimeters of mercury.
Dr. Ananya, at this moment, the child is 2 months old?
No, currently the child is 1 year and 2 months old, sir. Okay. This was the past history of the child.
Okay. This procedure was done at 1 year, 2 months.
The procedure, the PDA device closure was done at 2 months of age, sir.
So 2 months of age, 10-8 device.
Yes, sir. It was a large 5 millimeters PDA.
Okay.
Post-procedure echo showed device in situ, no residual PDA, laminar LPA flows, and there was a prominent ductal shelf that was causing some flow turbulence in DTA, but there was no coarctation. And there was some LV dysfunction. Child was started on dobutamine infusion for the next 48 hours and was discharged with tap cardiac. The lower limb pulse was felt at the time of discharge. So we anticipated that the child might develop coarctation in the future and hence kept the child on close medical follow-up every 3 monthly. During the follow-up, we noticed that the DTA gradient progressively increased. It was 25 millimeters to start with, which increased to 50 millimeters of mercury with diastolic tailing at follow-up. And at the current follow-up of 14 months, the child, though was asymptomatic, had absent lower limb pulse. Echo showed severe coarctation of the aorta with the gradient 50 millimeters of mercury with diastolic tailing. PDA device was in situ with laminar LPA flows. There was concentric LVH and good biventricular function. So the options were we could either do a balloon coarctoplasty or stenting. So we went ahead with transcatheter approach. The procedure details were as follows. We got a gradient across cork segment of 34 millimeters of mercury. And then this angiogram, which was taken in the LAO 50 view, we can see there is a discrete coarctation caused by the prominent ductal shelf. The PDA device is in situ and there is no residual PDA. Another injection is given to delineate the left subclavian artery. We see it is quite distant from the cork segment. So following concerns were raised regarding the next management. Suppose we did balloon dilatation, then we felt it wouldn't have yielded because of the anteriorly placed device. The next option is placement of a stent, but stent placement would require a 7F sheath and this child weighed only 9 kgs. And also we had to keep in mind that the stent should be expandable when the child grows up. And also we had to take care that the left subclavian artery is not chilled. With all this in mind, we went ahead with coarctation stenting. Coarctation stenting was done with a 10 into 20 mm formula stent. So here we can see we have done coarctation stenting, and post-stenting angiogram shows good flows across the corked segment, and also we have not jailed the left subclavian artery. And the gradient also reduced from 34 to 2 millimeters of mercury. So in this case, we have tracked the stent over the wire without the use of long sheath support. So, and also we have taken extreme care that we do not lose the pulse at the access site. And the manufacturers claim that the Cook formula stent can be re-expanded to 200% with minimal foreshortening. So we have, suppose there is coarctation again, then we can balloon dilate in the future. Currently, it is at 10 millimeters. If we can achieve 200%, that comes to 20 mm. That is almost like adult size. Thank you, sir.
Thank you, Dr. Ananya. I just asked that question in between to understand at 2 months of age, your coarctation, your PDA warranted a 10/8 device. I would rather feel that is too large a size of a device for a 2-month-old baby. What was the weight of the child during that time? Because it is basically, yeah, it's an aortic protrusion, aortic disc protrusion into the aorta causing an acquired coarctation. Rather, it's not truly an embryological coarctation. It's a large disc, an aortic retention skirt protruding, a 14 millimeter aortic retention skirt of a 10/8 device protruding into the aorta. So that was a concern. One interesting point that I observed during your presentation was that you took the stent directly without a long sheath. Is that right?
Yes, sir.
Does that mean you did not have even a 7 French sheath in the groin and you just pushed the stent through the femoral artery?
In the groin, we had a 7F sheath, sir. We didn't use any long sheath.
Okay, okay. Does that have any impact, like a long 7 sheath versus a short 7 sheath on the vascular access complication? I think it will be more or less be the same, no? Whether it's a 7 long or a 7 short. The
injuries at the iliac bifurcation can be prevented, is what I read in some articles, sir.
Yeah. Thank you very much. That was a wonderful presentation. Shak, any points to add, Shak?
I think the main thing, really, you've alluded to it already, and that is the echo showed a wide distal aortic arch before anything was done. There was no coarctation, and so this is a device-induced coarctation, isn't it?
Yeah.
And then it becomes a tough one, because if you put in as big a device as was put in, you've got device occluding quite a bit of the aortic lumen, then you're dealing with it with a coarctation stent. So yeah, that's a tough one, I'm afraid.
Yeah, actually in some centers might actually sort of undersize the device in very tiny babies with PDA. For example, if a 5 millimeter PDA, some operators would like to see whether a 6/4 device itself will be able to be an occlusive device, because the fear is when we go for a larger and larger device, the descending aorta is not as roomy to accommodate such a large sheath. Any brief words from Worakan and Peter?
Oh, for me, would love to see the angio on that day. Unfortunately, we don't have it. But another possibility, if we can use a vascular plug, and perhaps AVP2, just put it inside the ductus if we could. But that is also run the risk of migration embolization. So these are the things that there's a trade-off. You need to be very meticulous on the device selection if you really need to do it at 2 months old baby. Thank you.
Thank you. As time is
running, may I add one point?
Yeah, please, Krishnamurthy.
This small babies PDA closing with a large device, very often you have seen they end up with LPA obstruction also, even though there is no obstruction in the LPA, even with angio or echo after the procedure. On follow-up, they develop LPA obstruction and they require surgery on bypass, and the removal of the devices at this time for the surgeon is very difficult.
True. I think Krishnamurthy, the take-home message is, in a very tiny baby, when we are taking up for any device for that matter, whether it is an ASD, VSD or PDA, undersizing will be better rather than oversizing, and keep the device as small and sweet as possible so that it doesn't encroach on to the other areas. May I request the fourth presenter, Dr. Thejaswi. Please, Thejaswi, sharp.
Yes. Good evening, everyone. I'm Dr. Thejaswi from Madras Medical Mission. I'll be presenting a complex case of coarctation in a patient with compromised vascular access. The primary operator is Dr. Sasikumar. Our patient is a 28-year-old lady from the Middle East. She was diagnosed with post-subclavian coarctation of aorta and a restrictive VSD. Her first procedure was a stent coarctoplasty done when she was 19 years of age at a center in her own country. A CP stent was used. However, we have no further details of the procedure available to us. The relatives were told after the procedure that the stent was incompletely expanded and there was a residual gradient after the procedure. She underwent a second procedure at the same center after a few months, during which the right femoral artery was injured and an iliofemoral interposition graft had to be done. This graft was also told to have been occluded on follow-up, and then she was referred to us for further management. When she presented to us, she complained of class 2 exertional dyspnea, and she also had systemic hypertension. On examination, the right lower limb pulses were absent. Her left femoral artery pulse was palpable. However, there was a bruit heard in the left inguinal region. The clinical coarctation gradient was around 40 millimeters of mercury between the right upper limb and the lower limbs, and there was a 5 to 6 millimeters of mercury gradient between the right and left upper limbs. Echo showed a restrictive 5 millimeter high muscular VSD shunting left to right, a dilated hypertrophied LV with normal LV systolic function, and a coarctation gradient of 50 millimeters of mercury. This is a CT of her aorta, where, as you can see, the distal part of the coarctation stent is incompletely expanded. The CT also showed complete occlusion of the right proximal common iliac artery, which is pointed to with the arrow head, a left femoral AV fistula pointed to with the arrow, and also which drained into a dilated common iliac vein, and a left common femoral artery pseudo-aneurysm just above the AV fistula. This is a multiplanar reconstruction of the pseudo-aneurysm and the fistula in sagittal, axial, and coronal planes. And in this coronal plane, you can see the dilated common iliac vein as well. So we had to address a few issues in this patient. The first being the incompletely expanded stent leading to severe coarctation, and restenting this would require a 9 to 10 French sheath at least. We had to do a device closure of the VSD at the same sitting and also address the left femoral AV fistula and pseudo-aneurysm. Regarding the axis, the right upper limb arteries were the only clean axis sites available in her, as the left upper limb had a jail subclavian artery. The right lower limb was completely occluded, and the left lower limb had this common femoral AV fistula and the pseudo-aneurysm. We evaluated through imaging the left femoral artery for a possible site of puncture. And as you can see here, axial sections at 3 levels, A, B, and C, are demonstrated here. Here at the highest level, there was a pseudo-aneurysm. Just below it, an AV fistula. And below the AV fistula was a clean segment of the artery. We measured a 2 centimeter distance between the AV fistula and the division of the common femoral artery. And we thought that we could use this as a puncture site. An ultrasound-guided puncture was done in the left femoral artery, and angiogram was done using a cannula to confirm the puncture site was located below the level of the fistula and the pseudo-aneurysm, as shown here. A 9 French sheath was introduced through this, and the sheath angiogram, as shown here, demonstrates that the puncture site is located below the AV fistula. A 6 French right brachial axis artery was also taken. Now, an aortic angiogram was done from the right brachial artery axis, which demonstrates severe coarctation at the distal part of the stent and partially jail left subclavian artery. A guide wire was advanced from the left femoral artery, and initial balloon dilatation was done with a 10×2 Mustang balloon so as to create space for the larger sheath to pass through. We then took a 35 mm bare Andra XL stent mounted on a 12×4 Admiral Extreme balloon, and the stent was positioned so as to overlap the distal half of the older stent. We were unable to completely expand the stent, and the serial post-dilatation was done using a 10×2 Atlas Gold balloon, followed by a 14×2 Atlas Gold balloon. And as you can see in the second angiogram, the waist completely disappeared with the 14×2 Atlas Gold balloon. Final post-dilatation was done using a 16×2 Atlas Gold balloon. And using the same balloon, we advanced the sheath across the stent and addressed the VSD using a 6×6 ADO2 device. Now to the second part of our procedure, which was to address the fistula and the pseudo-aneurysm. We debated between use of a device and covered stent, and chose a covered stent because as both the pseudo-aneurysm and the AV fistula can be addressed together, and also the puncture site can also be addressed using the same covered stent. The femoral artery bifurcation was marked using a needle placed on the skin, which served as a marker for placement of the lower end of the covered stent. The stent was advanced from the right brachial artery axis, which was upsized to an 8-French sheath, and a 10x60 Covera plus self-expanding stent was used, and it was positioned so as to cover all three, the pseudo-aneurysm, the AV fistula, and the puncture site. The same sheath was used to achieve hemostasis, wherein the sheath was gradually withdrawn while deploying the stent, as shown in the first angiogram. These are the final angiograms, which demonstrate good flows in the left femoral artery with no residual fistula or pseudo-aneurysm, and hemostasis was also achieved without any leak. This is an aortogram showing good flows across both the stents and good flows in all the arch branches. She did well on follow-up and was discharged with aspirin and metoprolol. At 1 year of follow-up, she had normal left femoral artery flows on Doppler, and blood pressure was controlled without any medications. This is a follow-up CT at 2 years, which shows a fully expanded coarctation stent and covered stent in the external iliac artery and common femoral artery with no pseudo-aneurysm or AV fistula. Our take-home messages from this case were that the vascular injuries are very important complications of coarctation stenting. Incomplete expansion is common in severe coarctation and may need high-pressure balloon dilatations. Compromised vascular access is a challenge for re-interventions, and pre-procedural vascular imaging aids in compromised vascular access. Thank you.
Thank you, Dr. Thejaswi. Dr. Shak, any points to add, Dr. Worakan?
I've lost count of number of complications you started with. It's a very, very challenging case, isn't it? And how to, you're trying to work out which is the worst one, and obviously the not fully expanded original stent is the major problem, and then all the other things. And you've done really well to address all of the issues there.
Peter, any ways in which this could have been done better?
No, I think this was a perfect procedure. I always wonder how the stents in the femoral artery very close to the joint where there's movement and muscle work, that they stay open and do not cause any aneurysm by itself. But as shown, the long follow-up is good, and we have stented some femoral arteries too, and somehow they stay open. It doesn't cause any harm.
Yeah, fortunately this puncture site was above the inguinal ligament, and hence it was good. I think your point is very important. If the stent is going well across the flexures of the groin, I think it carries a risk of injury. Worakan, any points?
Fascinating case. Thanks for your resident and also the team. Congratulations. Just curious that for the occluded right femoral artery, any chance that we can recanalizing it? I mean, I don't know.
We thought about it. It was a 3.5-year-old chronic total occlusion. This occlusion was documented within 3 months of the procedure. After they did the procedure, within 3 months, they had documented that there was an occlusion of the graft. And the patient was advised a repeat surgery, which she declined. And so I was not very confident of recanalizing a very long segment intra-graft. But maybe, I think we could have tried some chronic total occlusion, hard wires, and burnt through and through.
But the other question I had was, how did you select the Covera stent? Or why?
Basically, it was something similar to this Fluency. Fluency and Covera are the Bard's self-expanding covered stent. It expands to 10 millimeter. Our vessel was measuring around 8 or 8.5, so we decided to go for a 10. It is low in profile. So, I mean, we had only 2 options of self-expanding covered stent. One was Fluency and one was Covera, both by Bard.
The reason I was curious was that the Covera is the one that they recommend to use in AV fistulas, and that's why I was that seems to have been the design for it. So I was just curious how you managed to get it for that.
In an AV fistula, you put it across the AV fistula to maintain it patent.
Yeah.
Here we are going in the native lumen of the femoral artery and trying to exclude the. It's a traumatic AV fistula, so it was actually a very small orifice. So it was easy to. In fact, we even, as Thejaswi was telling, we considered putting in a small occluder there, but like a piccolo. But finally, I think.
No, covered stent is a good choice. It's just I was curious about the radial force of this stent, Covera stent.
We have used it on about 5 or 6 occasions, and it's quite good. It works well.
Yeah, well done.
I would like to request the next speaker, Dr. Arunkumar, on coarctation, stenting, pseudo-aneurysm. Dr. Arun.
So good evening, respected chairpersons and my dear colleagues. I would like to thank PPHACES and Professor Joy Joseph for giving me this opportunity. Today, my case for discussion is a post-coarctation stenting pseudo-aneurysm successfully managed by fenestrated TIVA. So he is a 67-year gentleman presented with cough with hemoptysis with past history of aortic bypass surgery for coarctation of aorta in 1997. Subsequently, he developed a giddiness, and evaluation they found to have a thrombused aortic bypass. And he again underwent coarctation stenting with CP stent 2340. So we proceeded with CT angiogram for the case. Here you can see an saccular aortic aneurysm arising from the proximal end of the graft. As well as the problem with the CP stent is it makes a lot of artifacts. In fact, we confuse whether these are small air pockets, which means the infected sac. So after analyzing the CT angiogram, our plan was to do a fenestrated aortic arch repair. Then how to do a fenestrated total aortic arch repair? This is a paper we published recently. So it consists of 2 parts. Any successful repair depends upon deploying the fenestrated graft with accurate rotational and axial orientation. So first step is planning. During the planning, we will exactly analyze the aortic arch branch ostial anatomical relationship, and we will exactly transpose those relationship into the graft. And you can see we will attach this figure of 8 markers, which is seen in the blue arrow. We can see in the blue arrow here, which gives at the 12 o'clock position, which gives us, which helps us in rotational orientation. And we make 3 round fenestrations for each of the branch vessels, and we resheath accordingly such that there is no twist in it. So during the procedure, second part, during the procedure, we make the plane of the arch, which is where the ascending and descending aorta overlaps each other. When we go 90-degree orthogonal to it, where the aortic arch is opened to its maximum. And you can see wire loop here, left common carotid to left femoral artery wire loop, which helps us in the axial orientation. So coming to the procedure per se, when you take the fenestrated aortic graft in the DTA, you see this figure of 8 marker attached in the 12 o'clock position facing at you. When we advance the fenestrated graft into the arch and into the descending aorta, we will rotate the graft such that the figure of 8 appears as a small straight line and at the outer curvature of the aorta. That gives us that the stent fenestrations are oriented superiorly. And you can see the left common carotid fenestration here, which is just ahead of the this wire loop, which gives the axial orientation, and we start deploying the graft. And coming to the present case, we decided to go with a single fenestration in this case. It is a single fenestration for left common carotid artery, 8 mm fenestration after detailed analysis. And this is the angiogram. We took bilateral femoral artery axis, left femoral vein, left common carotid artery. And you can see the angiogram showing a saccular aneurysm arising from the proximal end of the CP stent. And you can also see the wire loop from left common carotid to left femoral artery. And we dilated the CP stent with Atlas 16 followed by 20 at 4 ATM. And here is the fenestrated endograph. You can see the figure of 8 here, which is looking a small straight line. That means my superior orientation is correct, or rotational orientation is correct. And you can see here the fenestration, which is just ahead of the wire loop, which tells me that it is the axial orientation is correct. And we expose the free flow on the first stent graft. Once we are convinced that both the rotational and axial orientations are good, we will deploy the rest of the stent graft. This after deploying, we again dilated with Atlas 20, and we through the fenestration, we stented the left common carotid artery with fluency 13.5/40. And this is the final angiogram. We can see still the sac is filling here. Probably we thought at that time is due to graft porosity. Then we thought usually we follow up after 6 months. In this case, we thought we'll call him after 3 months. We did an angio and we saw still the sac was filling here. And after a multiple angio shots, we thought it is a type 1 endoleak. Initially, we thought to attend from the right brachial artery axis, but not able to negotiate the track. Then again, we took this antegrade aortic axis. We take a transeptal axis, we float the Schwann-Ganz catheter well into the aorta and put a glide wire into it, and we take the sheath into it. And we tried again, but we couldn't able to succeed it. So we make the patient to lie prone. We puncture the sac directly with a Shiba needle, and you can see the track here. We embolized with the coil initially and make the sac became a cull sac, and they injected the glue into it, and you can see the cast it made it. So learning points in this case illustrates the past, present, evolving treatment modalities of coarctation aorta and its complication. Combined data from coast and coast, this I took from a recent editorial. Trial on long-term follow-up showed good hemodynamic results, but there were late complications at 5 years like stent fracture, re-intervention, and aneurysm formation up to 6.3%. This unexpectedly increasing occurrence of late aneurysm is seen in both bare metal as well as covered CP stent. The treatment is mainly focused on relief of the obstruction, but there is usually an underlying aortopathy in coarctation of aorta. Fenestrated TEVAR may be a treatment option for such cases. We usually use endurant aortic tube, maybe an alternative for BMS in coarctation of aorta in adult, as it conforms to different vessel sizes and geometry with good positive remodeling in follow-up and possible prevention of late aneurysm formation. Always preserve left subclavian artery as it may be needed for future CABG if needed, and it is an important source of spinal collateral circulation. Thank you.
Thank you, Arun. It was a wonderful case. If I understand correctly, the reason for this aortic pseudo-aneurysm, 2 of them were something related to this previous CP stent angioplasty?
Might be, sir.
Because it was one was at the edge of the stent, the second one was looking remote.
Yes, sir. That is actually the distal anastomotic site of the bypass graft, which you can see just the initial filling. After that is completely thrombosed.
So the patient had a end-to-end bypass.
End-to-end or subclavian to bypass. We didn't know, sir, because it is 1997.
No, subclavian you jailed. I saw that.
Yeah.
But so it was possibly an interposition graft between the pre-coarctation aorta and the post-coarctation aorta.
Yes, sir. He didn't have any details of it, sir.
And then a stent angioplasty was done subsequently.
Subsequently in 2011, and in 2022 December we intervened for hemoptysis, probably rupture into one of the lungs.
Okay, Shak, it was just I was curious to note what was the reason for that pseudo-aneurysm. Obviously, during the stent angioplasty, it would not have been there because the operator would not have done the stent angioplasty. So, if there is a aneurysm, a pseudo-aneurysm, an aneurysm that is occurring at the edge of the stent, I can understand. But there was a second aneurysm that was a little distal. That was perplexing. And second thing, it was amazing that you were able to puncture through the chest and you entered into that aneurysm sac and you injected glue into it.
Well,
no, sir,
that was
back, sir.
That was going to be my question, how you accessed what position?
Sir, in this CT, we can clearly see, sir. So we can see the sac is here. So if I puncture paraspinal here, I can just enter the sac. So this is our landmark. So before the procedure itself, we thought, okay, if in case we couldn't able to access it either retrogradely or antegradely, we'll puncture the sac directly. So we made the patient to lie prone. We just punctured paraspinal between the vertebra and the spinal, the scapula. We just entered into the sac.
How do you avoid? Many of these patients will have intercostal arteries that are aneurysmally dilated in coarctation. And how do you avoid trauma to those areas? And how do we get control over such a?
Yes, sir. Yes, sir. So actually, we have done a few cases of total aortic repairs from ascending to bifurcation also. Usually we stage the procedure in those cases. Initially we repair till the celiac artery, then we give a maximum 2 or 3 months, then we'll repair below. But that's the reason we have to always preserve the left subclavian, because the collateral circulation to the spinal arteries mainly from the internal iliac arteries and as well as the subclavian arteries. So it is always better to preserve the subclavian. If in case in future he needs a repair which needs to be extended below, it might be a useful one.
The other thing about this was in TEVARs trying to preserve the head and neck vessels, and I think what you've demonstrated was an absolutely superb way of landmarks and getting your graft to point such that the head and neck vessels remain patent. Absolutely superb.
This is my chief, sir. He will receive the credit for it.
Actually, Dr. George Joseph is a veteran of aortic aneurysm stent grafts in India. And he very, very cleverly manages almost all the side vessels of the aorta, starting from renals to subclavians, renals to superior mesenteric celiac. Each and every vessel he targets with these fenestrated grafts. And he has a huge volume of data about these fenestrated grafts. Thanks, Arun, for a lively presentation. I think we are running short of time. The next presenter is a phenomenal operator, very young guy from India. I'm very proud to introduce Dr. Srinivas, who is an extremely intelligent and innovative operator. Over to you, Srinivas.
Thank you very much. Let me share my screen. Hope my slides are visible.
Yeah, very well.
This was a case which was done some time back, almost 2012, I think. This was a coarctation stenting and a PDA device closure in the patient with circumflex aorta and a large. What is circumflex aorta? Circumflex aorta, this is the normal aorta with the left aortic arch and the left descending thoracic aorta. So right arch has right aortic arch and the right descending thoracic aorta. What is circumflex aorta? In a circumflex aorta, you have an ascending right-sided aorta, then a circumflex arch, and a descending aorta on the opposite side. So this is circumflex arch. Okay, so this is an index patient, what I'm going to discuss. So this is an ascending aorta, this is the arch of aorta on the left side, and this is the circumflex arch, and the descending thoracic aorta is on the opposite side, that's on the right side. So when we look at it, the axial cuts, you have two different sections of the aorta. So this one is the ascending transverse arch, part of transverse arch, and also the descending aorta. So it's almost at the 90 degrees angle. So this is the anatomy of the circumflex aorta. So this was an 11-year-old boy weighing 27 kilos, height of 132 centimeters, less than 25 centile, presented with failure to thrive, fatigue on exertion, systemic hypertension, lower limb pulses were feeble, and had a continuous murmur at the left upper sternal border. Echocardiography diagnosis showed a large 8 millimeter left-sided PDA with left to right shunt on the echocardiogram and subsequently on the CT, but he had severe coarctation of aorta. So this is the anatomy. So now the first choice was to send him for surgery because it was too complex for stenting, and it was in way back in 2011. The dilemma for the surgeon was if he does a left thoracotomy, he would not be having an access to the right descending aorta. If he does a right thoracotomy, he will not be having an access to the transverse arch, the proximal part of the coarctation. If he goes through midline, so he will have difficulty in actually accessing the posterior part of the aorta. So for him, the surgery was very complex. What he suggested to the patient was to put a jump graft from the ascending aorta to descending aorta. So this was not acceptable risk for both the patient. And this patient actually was lost to follow-up for 6 to 8 months and roamed around a lot of places. Again, he came back for an intervention option. So this was the coronal plates. So now this is the ascending aorta. You can see in this cut, there's a severe coarctation of the aorta, and there is a large PDA at the junction of the coarctation as well. So now again, this is anatomy. As I said, the ascending aorta and the transverse arch are in one plane. Descending aorta and the distal transverse arch are in the second different plane. So our plan was to close the PDA with a ductal occluder. Second step was to stent the coarctation. So we used to do cutdowns at that time, so we did not have per close devices and such things in 2011. So we chose for an elective cutout, also obtained the left radial artery access. Crossing this defect was quite difficult because whatever I do from the femoral axis, the wire would go into the main pulmonary artery via the ductus. So it was not possible to cross. So what we did was the coarctation from the left radial artery axis. So in this case, it was very easy to cross. In fact, the pigtail itself actually hooked the coarctation and went into the descending thoracic aorta. The wire was snared from railroad was formed, and we proceeded with the procedure. So now this one has similarity to what we saw on the coronal CT. So we proceeded with the stenting first. PDA device first. So into 14 heart R device for closure of the PDA. Again, very limited landmarks. So we mostly depended on the echocardiography images for sizing the PDA. So because whatever angiograms I did on the table, I was unable to define the PDA so well. The first step was successful. We closed the PDA. So now once the PDA was closed, the anatomy better defined. So next step was to predilate this with a balloon because I was unable to pass a 14 French Moulin sheath over this in spite of having a radro. So we predilated this with a 6 into 40 mm PTA balloon. So once we did that, I passed a 14 French long introducer sheath from Cook's, and then we proceeded with stenting this part. So we deployed a 14 into 50 millimeter bare metal Palmas Genesis stent, which was mounted on a 16 into 40 Atlas balloon. And this was the final result after stenting. The coarctation segment was very well open. There was no residual PDA as well. Next step was to release the PDA device. So PDA device we did not release till the end because we were not very sure whether this PDA device will jump out when I actually deployed the coarctation stent. So this was a 3D reconstruction of aorta just in case to look any pseudo-aneurysms or aneurysms after the stenting. So the result was perfect. So there was no problem at all. This was another view. So points for discussion is that why this patient does not have a vascular ring. This patient does not have a vascular ring because the ductus was on the same side as the transverse arch. So if we had a ductus on the opposite side of the transverse arch, you would have had a vascular ring. Then our therapeutic catheter options would not have been possible. So this was anatomy of the patient, as you can see. So the entire vascular anatomy was on the left side of the patient. The right side of this was completely open, and so it was not a vascular anatomy at all. So choice of implants, why two procedures? Why can't we just use a covered stent? So as I said, this had a very weird double 3D anatomy for this covered stent, and such a stent is not available. So this is just a imaginative model of this Boston Scientific Texas element. It's not available. So now if I put a covered stent here, so what would happen is the covered stent itself would occlude the transverse arch completely, and there would be a gradient because of the cover. So this was out of question. Second issue that I had in my mind was if I put a covered stent to close the PDA, because the distal aorta, descending aorta is so wide, if I do not cover the entire mouth of the duct with my covered stent, there would be a residual PDA as well. So once you have that, then it is impossible to close this PDA. So I chose not to put a covered stent. So third problem for me was the size of the femoral vessels in spite of having a cut down. So the femoral artery sizes were not very great to take any sheath more than 14 French. So this was a reason. To conclude, circumflex descending thoracic aorta with coarctation in an ipsilateral PDA is an unreported anomaly. Does not amount to a vascular ring. CT angiogram with 3D reconstruction is vital to understand anatomy and plan the procedure. Thank you, sir. Thanks for the opportunity.
Thank you, Srinivas. Yeah, quite a bizarre anatomy, handled extremely well. You pointed out very clearly that in a left circumflex aorta, if there is no right-sided ligamentum arteriosum, there is no complete vascular ring, and I agree with that. But then you are something like you are having like an LPS sling. There is an aortic sling now. The aorta is actually coursing anterior to the trachea, and then on the left side, and then it is coursing behind the trachea. So when you are planning a stent angioplasty of the portion that is behind the trachea, was there any thought that was running in your mind that this dilated, expanded stent might push the trachea from behind and sort of bend it? Because the posterior part of the trachea is the membranous part of trachea, anterior part is the cartilaginous part. So when your stent is lying in the retrotracheal or the post-tracheal part of the aorta, did you have any concerns about this interaction between an expanded stent and the posterior tracheal wall?
Sir, here I think the structure that was immediately in vicinity of the stent was esophagus and then the trachea. This was not a small child, so he was already 11-year-old boy. So I think that much space would be available for accommodating this stent. That was my thought process.
Yeah, that was good.
I think we would have, it probably would have been too late, but I think we would have done a bronchoscopy at the end of the procedure, just to be reassured that there wasn't going to be a problem in the longer term, but just because of that concern about possible compression on the
So now the follow-up is now almost 10 years, the child is still doing well. The stent is created.
Shak, in probably in 2011, when Srinivas was doing this procedure, I would not have been very aware about all these things, but now you hear Gregor Kings and this Amy Armstrong talking a lot about interaction of various vascular structures to the bronchus. Now probably I think we will do far more. Yeah, I think it was a very good case, Srinivas. I think that we come to the last part of the presentation. Dr. Sridhara Suthan. Dr. Sridhar, can you share your screen? Please go ahead. Sridhar, are you muted?
Sir, am I audible? Good evening, sir.
Yeah, you are audible. Please.
Yeah. I'm going to present an interesting case of transcatheter reposition of aortic coarctation stent 1 month after mole deployment. A 29-year-old male with poorly controlled systemic hypertension with despite 4 antihypertensive medication, diagnosed to have dextra subclavian coarctation 2 years back, and the primary CT, pre-posterior CT showed a Gothic aortic arch, and the aortic dimensions were like 18 mm at the left subclavian margin and 8 mm at distal isthmus and 4 mm at the level of coarctation and 26 mm beyond the coarctation. The coarcting segment was 25 mm beyond the left subclavian margin, and following a hemodynamic assessment, the cardiac appreciation showed 45 mm of gradient, peak-to-peak gradient, and the coarctoplasty was done using 57 mm PTFE covered anteroaxial stent mounted on 16 mm balloon elsewhere in some other institution. And during the stent deployment, the stent migrated proximally in such a way that the anterior surface of the covered stent was partially obstructing the transverse arch, and the posterior surface of the covered stent was abutting the left subclavian. Patient presented to us 1 month after the initial procedure with the right upper limb BP of 180/80 and the left upper limb BP of 140/80 and lower limb BP was 110/80 mmHg with the refractory hypertension. And we did echo, which showed peak gradient of 79 and mean gradient of 25 across the proximal stent. And we had 2 options: surgical removal and aortic arch repair with extreme surgery. And second option was the transcatheter reposition. The transcatheter reposition is not reported earlier in literature, and we know that usually complete re-endothelialization occurs by 2 to 3 months in coronary stents and even more in larger stents and with covered stents. So we decided to go ahead with transcatheter after patient consent with the surgical backup, and 3 axes were taken: right radial artery axis for the pigtail angiography to guide the procedure, and right and left femoral artery axis were also taken. And there was significant gradient of 75 mmHg between ascending and descending aorta. And through the left femoral artery, 25 mm gooseneck snare was advanced, and through the right femoral artery, end-hole catheter with the guide wire was advanced through the loop of the guide gooseneck snare. Subsequently, it was advanced through the lumen of the covered stent, and it was parked in the ascending aorta and the aortic root. And that catheter was exchanged with the low profile 12 mm Mustang balloon, and that lower part of the stent was gripped with the loop of the gooseneck snare, and it was crimped partially and pulled cardally. A little bit force is required to dislodge the fully expanded stent around the walls of the aorta, and we pulled the stent successfully. and the lower part of the stent was dilated with the 12 mm Mustang balloon, and the angiogram showed stent distal to the subclavian, and there was no major intimal irregularities at the ischemic part, and the ischemic part narrowing was measuring around 14 mm, and the gradient was 20 mm between the ascending and descending aorta, and it was decided to take a bare metal stent of 35 mm anteraxial stent over a 18 mm balloon, and it was placed distal to the left subclavian artery, overlapping the previous covered stent. The bare metal stent was chosen to avoid obstruction to the left subclavian artery and to also give the support to the previous covered stent. And it was deployed, and the overlapping segment was also post-dilated. And finally, there was no gradient, and at 1 year follow-up with no complication, and patient is now on single anti-hypertensive medication with the BP of 120/80. So take-home message was like post-coarctation stent mal-deployment is extremely rare, and covered stent in this scenario leads to obstruction of arch and branches. Using right radial access for angiogram and using anatomical structures as landmark prevent this complication. If happens, immediate snaring cardially would suffice, and complete reintervention occurs almost 3 months later, and delayed reposition is still feasible, and maintaining the track using the wire is the key factor. Thank you.
Thank you, Sridhar. I think the net connectivity was not great, and we were actually seeing the pictures like 1950s movie, like it was very faint. But thanks for the presentation. Dr. Shak, Worakan, Peter, any points? And then
yeah, so I've got years ago I had one stent embolized, migrated really is the right word, upwards, so proximally, and did pretty much exactly what you showed. And we immediately put another balloon inside and pulled it down into position. And there and then, if you recognize it, it's much easier to do it that way than, I mean, what you've done is you've achieved it. It's excellent. It's a complex way, but I'm just curious about originally when it had migrated upwards, why not try and reposition it acutely?
I think so. I think that will be a very, very good strategy, just to push in the same balloon, inflate it to the maximum and drag the balloon down so that you can get it back to position. I think, but this was happening somewhere else, and then we got to see this patient about almost 1.5 months later. Yeah, but I think your point is very, very, very good. I think if there is a proximal migration, try to reposition it immediately, which is with the guide wire, with the balloon, everything in place. It's possibly a bit more easier.
Yeah.
Peter, yeah.
So what will be your choice of balloon in case you have to reposition this particular stent?
Maybe we can use the same balloon, or maybe 2 millimeter larger. If you are doing it acutely, like you have deployed it.
If you're doing it acutely, I would use the same diameter, because if you use a larger one, it's difficult to control your pressures, and if you expand the stent, it makes it difficult to pull back. So the same balloon would work much better.
Yeah. If it slips, then probably a larger balloon. I'm just curious. If the balloon just comes down with the stent remaining in the same place, then you may have.
Well, we have gone a little bit more proximal still with the balloon, not inside the stent, and that's helped to bring it down.
Yeah, I think so.
Check. Let's say if you're gonna do this case, a few weeks after implanting, will you considering using balloon techniques to pull it back first, or use what Deepa's team mentioned?
Yeah, I think if it's less than 2 to 3 months, then I would attempt balloon and pull down first, before, because again, whichever technique you use is going to have some technical challenges. And so it's a snare and so on, again, will be challenging. So I would attempt the simpler method first and then go on to the more difficult one. There's a question in the chat box about possibility of dissection, and yes, the answer is dissection, yes, but then you have to be prepared to put in a covered stent, an additional stent. Occlusion of left subclavian is only really if you're pushing the stent upwards rather than pulling it down.
Yeah. Any concluding words, Peter?
One comment.
Yeah, please.
It's seeing so many complications and scary procedures. Hope it doesn't deter the juniors from embarking on coarctation.
Well, the important message for the juniors is that they should not be learning to make the same mistakes that their seniors have done, but to learn from their mistakes and avoid making them when they're doing.
But Krishnamurthy, one thing I'll tell you, the incidence of coarctation complications probably in this last few years is much less than what we used to create 10 years or 15 years before.
Agree.
Peter, a couple of concluding words, and then actually I'm very happy to see you, Peter. It's very rare that in an Indian meeting we get a person from Germany, and it's so pleasing to have you in this meeting, and I thank you for it.
It's the pleasure is on my side. I've been traveled several times through India from north to south, and I love that country and the people living there. So coarctation is looks simple, but as already mentioned, it's a complex and it's a high pressure field. So things happen very roughly and very quick, and you have to always be alert to deal with any complication you can imagine.
Just to say, emphasize what Peter mentioned also. I think it's not over until it's over. I mean, even if your procedure finish, successfully, but be aware of the, even you try to withdraw the sheath, secure the exit. I mean, the vascular entry point. These are also important, and this would happen anytime, during the procedure. So, to me, I'm still, very aware in all the cases of coarctation. I don't know, but this is what I'm still alert and be always have a plan B. So just to emphasize all the juniors.
Yeah, I think it's a fair point. Neeraj, any concluding remarks? And then
I think all these team people have already talked of the wonderful thing. But planning what is the most important step of coarctation, as is true for any other procedure. And a long-term follow-up is very much important, as the complications have already highlighted the same. So, thank you.
Thank you very much. I think it was a wonderful meeting, and I request Dr. Arun Gopalakrishnan to give the final concluding remarks.
Thank you, sir. I think it's appropriate that Dr. Deepa does it, because she has done so much of planning, and good that we've had such a nice meeting. I thank Dr. Sasikumar sir, Dr. Shakeel Qureshi for joining us and leading the discussion forward with Dr. Peter Zartner, as already Dr. Sasikumar sir has mentioned. Very nice to have you from Germany, and Dr. Worakan and Dr. Neeraj Awasthi. Dr. Neeraj Awasthi, as we know, is busy with another event as well. So thank you for joining despite the busy schedule. And all the presenters, we've got Dr. Vinothkumar, Dr. Gousia Mukhtar, Dr. Ananya Shetty, Dr. Thejaswi, Arunkumar, Srinivas, and Dr. Sridhara Suthan. And Srinivas sir is not just a presenter, he is a teacher. And thank you. And Krishnamurthy sir and Dr. Deepa led it from the front. I hope all the delegates attending the meeting had a wonderful session. And with this, we come to the end of it. And Krishnamurthy sir, we'll hopefully carry on the session in another episode.
Yeah. And a word of thanks from my personal behalf to Sir Qureshi, Peter, Worakan, Neeraj, Dr. Srinivas, and other presenters, Dr. Siva. Thank you very much for joining us and enlightening us. Thank you.
Thank you very much, everybody. Thank you.
Thank you.
Thank you.
Thank you.
Yeah. Good night.
Night.
Thank you. Good night.
Good night.